Okay. Well, welcome everybody. IT is brilliant. We live and die by technology, but we're doing a little bit of both right now. Anyways, I'm Dr. Facer. This is my assistant, Lindsay. This is my office. This is what we do. We're going to do a root canal on tooth number 7 right now. Just real quick, the diagnosis is pulp necrosis with chronic apical periodontitis. Lindsay, if you want to go full screen with the x-ray, we'll take a look at that.
This x-ray?
Yeah, we'll start with the 2D. So, just full screen, yeah. So no history of trauma with that. If you look at the x-ray, it's a pretty lucent lesion. Now, ironically, if you want to go open up the cone beam now, Lindsay. And when we did our pulp testing, number 6 looked involved, but it did test vital. Lindsay, if you want to scoot the green line over so we can take a look at what 6 looks like. There you go. So, you know, it's definitely got rarefaction around that. It's probably just extending from tooth number 7 as it still responded to the cold testing. So we're going to focus on number 7 today. And let's get a length here, Lindsay. Measure the bottom right view. I tend to do a lot with the cone beam, and just kind of we'll confirm with an apex locator as well. Let's see. I think you started a little high. Try that again. Just try to dial that in right on that apex there. There you go. All right, 23. Okay, so we got a great participant here today. Now, Linz, let's get some topical in here. All right. To number 7. Now, she does have a history of palatal swelling, and her palate is fairly swollen. So we are going to anesthetize both sides. Let me see a mirror, please. All right. Okay, bite down. All right, easy does it. So we all know under the nose is a little bit tender. Now, one of the ideas that we have with doing these sort of live procedural feeds are kind of just showing you a variety of everything. The wish is to start with just this anterior, and we'll talk about how I do the technique, and then a molar, and then we'll actually do a retreatment as well. Not all today.
And I'll give you a wrench in just a moment.
Okay, let's have you open wide. Nice and easy here. Well, Lindsay, if you want to go back to while I'm doing this, if you want to switch to the 3D cone beam view, and we can show them the missing palatal bone. So just make that bottom right screen big. You got to go to the bottom right, hit the big box on the bottom right. There you go.
Oh, up here, right?
Yeah.
Okay. Here we go.
There you go. Now, if you want to dance through the different 3 planes on that, just do the yellow, purple, go back and forth. Just show the audience what's kind of going on. In fact, why don't you go back to the 3-plane view? Just shrink that, the other one. Same one you touched before. And then dance through that all. See the nasopalatine duct, it clearly looks like 6 is involved, although it's a pretty obvious response to cold today, as we talked about. And 7 was definitely necrotic. All right, you can go back to the... So we're going real slow here. It is quite tender up here and quite swollen. You know, a lot of times anesthetic goes a lot quicker with this, but this one is just so tender. We're just going to drip it in. The poor palate is very swollen. Okay, there you go. All right, let's give you a break here. All right. Good job. You want to go to the intraoral now? All right. Okay. All right. You want to turn down that brightness and contrast just a tiny bit. There we go.
Better?
Yeah. Okay. Alrighty. So, you know, a lot of people isolate kind of differently, and for me, I'm just kind of a single tooth isolation guy almost always. There's going to be occasions where I can achieve that, but in this case, that's what we're going to do. All right, let's get some floss.
Okay.
Get through these contacts a little bit better. All right, mirror. Okay, so we got the isolation. Make sure that clamp's going to stay on there.
Put a bite block in.
Yep, let's get a bite block in there. Okay, open wide. This is going to give you something to rest against. You can just bite against that. And let me see those forceps. I'm going to position that on just a little bit better. putty. Now, kind of carry over from residency, I always just do kind of a double seal technique. Nothing's worse than taste. And so we're just going to seal around this just a tad bit. There we go. All right. Let's take a look inside here. How are we on focus, lens?
Looks like.
Okay. All right. So, clearly we got a lot of pressure coming out of this. Yes. Yes, the tooth number is actually number 7. The lucency on the x-ray was around 6 and 7. 6 actually responded to cold, whereas 7 did not. And so we're running with diagnosis of pulp necrosis and it's acute apical abscess. And we're just kind of getting through some drainage here. You want to bring up the 2D x-ray? Alrighty. Okay, well, looks like it's starting to settle down a little bit as far as the drainage goes. I'm going to take a quick length with an apex locator. We did measure on our cone beam, but let's see how we measure here. All right. So I'm measuring 24. Look at my file. All right. So it's pretty patent. It's pretty open as is. Lindsay, can I get a 1506? All right.
What do you want next?
Let's go up to 25.
Okay. 25.
Yeah, you know what? A lot of what we're doing now is thinking about the GentleWave in mind. And one of the things that I've done is becoming more kind of directly parallel, so higher to the incisal edge. Candidly, because it just creates a better seal for the GentleWave. When I get a lot of drainage, I want to make sure I'm actually generating the mechanism of action and enough force to sort of drain what's going on in here. She also has a kind of a lingual groove defect kind of naturally in this tooth, which is probably a big reason why this abscess is so large. So I'm just going to look directly straight down that. I know when I use the procedural instrument now, I'm going to be just directly parallel with that canal. That's kind of my logic. There are size parameters, and we'll show you that when you get to the platform of what that should look like. Okay, Lindsay, let's get some alcohol. Yeah. So this is just a little cotton ball with alcohol on it, and all I'm going to do is just really dry my field. Basically, I'm setting the stage for the sound seal at this point. I did very minimal instrumentation. 1506 kind of went to my working length without even really feeling like it was touching anything. I did pass the 2504 file in and had the same sort of sensation. So this canal is much larger than that. But the instrumentation is really to set the stage for the GentleWave at this point. So the philosophy is a little bit different. The mindset's a little bit different. I'm going to go ahead and dry all this now. And that's just isopropyl alcohol. Kind of drying the rubber dam really does make it a little bit tacky. And I find that the sound seal does really stick well to that in this manner. Yeah. Actually, I don't think I'll need the sponge. So the platform looks like this. And there's a bunch of different techniques to do it, but what I like to do is, if I'm placing that as perpendicular as possible, I know my hands piece is going to run right on that incisal edge, my procedural instrument, and that's going to be that. So if I can build a platform in this manner, this is going to be very easy. And trying to get my hand out of the microscope here. I need 3 hands. You want to hold that for me right here, Lindsay? Just kind of keep it touching against the tooth like so. Now, there is 1,001 ways to build a platform. This is a way that I'm going to use it just to generate a seal. And all I'm doing, trying to demonstrate that, is I'm just filling up underneath this platform. And I'm going to come around the facial and just kind of connect the dots. Sometimes it's fun just to see a little bit of a tooth. Okay, I'll exchange this. Do you want to go ahead and cure that? Now, the platform to me is one of the most important parts of this thing, because creating the connection to the procedural instrument is where any of the flaws are. If it springs a leak, or if the seal breaks loose, then you're going to have issues. And so I really like to spend my time in getting this step right. The nice thing about the sound seal is I can always add to it at any point. And so if you get a little bubble, a little void, it's easy just to go ahead and kind of just reapply and recure. Now, if you look, I'm actually letting go of the hemostat. It's just sticky enough where it can hold that hemostat in place. So we got really good retention on it. So I'm going to break that seal, and then we'll take our first look at it. And you know, like I said, I can patch whatever I want in there. There's a little bit of flashing. How that? Let me see an Explorer. So I'm just going to go ahead and remove that to create a nice pathway. This is the little flashing that I'm talking about inside that access. So I'm going to go in there and just smooth that up. Now I want to be able to look directly down that from head to toe. And if you got any little bit of debris in there, you can pass another little file in there just to double check. So let's go ahead and do that, Lindsay. And when I'm looking inside this thing, I'm looking to make sure that's...
Michael S. said what type of clamp are you using?
Yeah, so the clamp that I'm using is a Weldent clamp, and it's actually a number 9. Weldent is a Coltine company product, I believe. So nice, clear, everything's good to go. So now I can set up, bring over the handpiece. So Lindsay, if you want to go ahead and bring that over here. And what she's handing me is GentleWave. Let's see. Now, this console over here on the side is going to go through a degassing phase. And so I'm going to set this up. And if you look in my hand mirror right here, I'm wanting to make sure as I begin, As it goes through a degassing phase, the fluids are coming through this procedural handpiece and down into the tooth. And what it's doing is it's pulling all the air out of the system. If you look really close, there is a little white bubble that's dancing. I'm going to break the seal for a second, see if I can demonstrate what it looks like. It's pretty tight, actually. If that seal is broken, it will look like a river, like a stream. Right at the tip of that, do you want to point with an Explorer, Lindsay, what I'm talking about on the mirror, if you can? The dancing bubble right there at the tip. Go up to the center in the window. There, a little bit. Yeah, that works.
Okay.
Right there.
Yeah.
So that little white dot is what I call the dancing bubble. And as long as that's right on top of that canal, the mechanism of action is actually working in this handpiece. And what it's doing is, as it pulls out all the fluid, which is almost done. Where are we at, Lindsay, on the percentage? Okay, we've just initiated the procedure. So degassing's done. This is going to run for 5 minutes. And the console is going to calibrate the sodium hypochlorite that's inside, and it's going to hum right around 3%. And my job is to make sure there's no leaks and to make sure that dancing bubble is just right on top of that canal. So what happens is you have basically this sound flow that's coming through this handpiece at very, very, very high speeds. And it's hitting this sound bar, and what it does is when fast-moving current hits kind of stagnant water, you create shear force. That shear force is what we get the word cavitation from. Now that cavitation bubble is what we're looking at. That little dancing bubble that I've been describing is the cavitation cloud. Now, it's not that that cavitation cloud is going all the way down the tooth. It's actually staying put. And that feature of that cloud collapsing and reforming generates lift and sound. And that's where we get the energy from to clean and disinfect. If you want to go ahead and play the video, we can. Corporate's got kind of an explainer video. And what that's doing then is, you know what, that mechanism of action is true of any liquid. So right now it's going through the sodium hypochlorite, but it's true if it was using water. It would create that same cavitation cloud and generate the same mechanism of action. And that's where we get sort of this protocol. And what's interesting about this protocol is there's kind of an endpoint defined in the research that Sonendo has done. And so by looking at who knows how many teeth, they know that if we run a concentration of sodium hypochlorite for, in this case, 5 minutes, that we are going to have cleanliness. And that's true if there's, in whatever space exists inside the tooth. So we can now go beyond just the primary anatomy. And so if there's a division, if there's a lateral canal, if we're on a molar and there's aberrancies, it's going to find its way into those aberrancies. So it looks like we got 2.5 minutes left on this procedure. And you know what's funny is for the first time in my career, my eyes aren't glued to the back of this microscope. I can tease my assistant, I can do other things. You know, a lot of practitioners will have assistants hold this when they get really comfortable with this. I tend to be a little bit of a control freak, so I just watch the dancing bubble. I want to make sure I can make this as effective as possible. Now, the way that the mechanism works is unique to this anterior premolar handpiece, and that's why they call it the APM. And it's used just for that, anterior and premolar. The molar looks a little bit different. Lindsay, if you want to grab a molar PI and just kind of maybe put it in the field of view, they can see that. But the results kind of speak for themselves. When you look at the screen to the left, these images that are popping up are done by other practitioners. They are very consistent with what the GentleWave looks like. So the molar, there we go. It looks like that. And that's the sound bar that's coming down through there. And so you know what? The look of kind of what I thought was a sexy root canal is now a little bit different. We want to see some fireworks and believe that we get advanced healing in that way. So let's see, we got a minute left of the sodium hypochlorite. So essentially the sound flow goes to the sound bar, creates the mechanism that generates the cavitation and the lift, and accelerated chemistry, because we are using sodium hypochlorite. And that's where we get sort of this advanced tissue dissolution. This suction, this negative lift that generates, is where we get this negative suction, if you will. And that's how the fluids are able to stay inside the tooth. Now, you know, having done this a little bit for a little bit of time, oftentimes you actually will drain abscess. Like the productive suppuration that was occurring at the beginning, you know, the hope is that we can end up with a dry canal at the end of this. Another comment is, when you go through this, sometimes you'll see some weeping of hemostasis, or not hemostasis, but bleeding into the canals, and that's fairly normal. I joke and say it's almost as if we're giving the tooth a hickey, but what we're doing is just generating circulation back inside through any of those little patent areas of the tooth or accessory canals of the tooth, and they will weep inside. Now, it's actually very easy to control, and we'll demonstrate that here in a moment. We have, looks like we've gone through the rinse cycle here. Now this console is going to, and it does it all by itself. I'm just holding this, and if there's any spurts or leaks, Lindsay can suction that up, but we're really pretty darn dry right now. Okay, so we've gone through a rinse cycle, and it's cleaning out the lines, cleaning out the bleach from the lines in the tubing in the tooth. It takes about 30 seconds. And then EDTA begins, and it's just passing through the same tubing. And this will run at a concentration, it hovers around 8%. The dancing bubble's doing good. And it's not quite as long. In anterior premolars, it's 2 minutes. The molar protocol time is actually a little bit shorter. So we have 1 minute left. Lindsay, do you have any funny jokes?
No.
Just about done, 30 seconds. And again, if there's a lot of movement or if your handpiece is wiggling around, sometimes you can break a seal, but when you're really perpendicular and parallel down the canal, this seal is pretty stout. I'm wiggling it around and it's still dancing in the same spot, which is a great sign. If there was a crown, if there was leakage, whether it be from the sound seal or under a crown margin, again, you would see kind of a stream develop in that window, a foamy stream. The other thing is everything this is putting into the tooth, it's actually taking out. So your access size also needs to allow exhaustion. Just like in your car, we've got to exhaust what we put in so we don't get any positive pressure. So that's the aftermath. Let's take a look. Let's clean this mirror a little bit. And let's remove. And I'm going to flip this under, and you can see it's just like an impression of that tooth. For whatever reason, I always make a little window in it, just maybe for orientation or whatever. But that's the way that the inside of that looks. Now, let's look inside this. So Lindsay's handing me hypertonic saline, which is 3% saline. And if there would be bleeding in the tooth, we would see it at this point, although this is fairly dry. My estimated working length, I'm going to leave saline in just kind of inside that access right now. And I'm going to do a cone fit. And to double check my length, it's just sort of measure twice, cut once. So the last file I used was a 2504, so I'm going to grab the 2504, and I'm just going to take a quick measurement, see where this goes. And we are right on 24, maybe a little bit past. So I'm going to go up a size to a 30. Okay, so let's go ahead and take an x-ray, Lindsay, and see where we're at here. You know what? The first thing that's changed is I've gotten smaller. The sizing, I mean, you're limited to what you're given, and that might be in a retreatment is what it is, what the previous shape was. Or in natural anatomy, I mean, I've done this on as large as like a size, apical gauge size of 120. In some trauma cases, you really see that. So, you know, I try to respect as true to form as possible. Lindsay, if you want to go full screen.
Okay. Will that work with the nose ring?
Yeah, I think we can see past the nose ring. So, I mean, I'm right where I want to be. I'm right where my apex locator told me was the terminus, and it's a good cone fit. I have some tug back. The idea is we still want to control the obturation materials inside the tooth, but if anything's open laterally or apically, I do want to fill that. And so I used to coat a cone with sealer and do kind of a continuous, my version of a continuous wave technique. Now what I do, I'll demonstrate it. We're going to inject inside here once I make sure this is completely dry. So, yeah, let's take this out. Cotton pliers. So there's my cone. I'm not seeing any drainage coming through here. Double check with some more saline. Now, one of the things I do is I just like to kind of cannulate anything out in there to get the bulk fluid out. And then I'm going to actually place a paper point inside there. You can go up to a 30. So just a little bit of weepage there, so we'll keep going until it gets bone dry. Just pause for a minute. Sometimes if you are dealing with some hemorrhaging, you don't want to keep kind of picking the scab. You just kind of let it create a little bit of positive pressure and let things kind of settle down. You can express hypertonic saline out the apex, actually. It poses no postoperative pain, and it really does help control the environment. One last one, we're just about there. I'm just looking at the tip of these paper points.
Ready?
One more. Forever the perfectionist. All right.
Ready?
Yep.
Okay. Sealer?
So I've got sealer in this compression syringe. This is actually an Ultradent compression syringe. And I'm just going to kind of backfill the entire canal. My philosophy is I want this to go wherever it's going to go. It's minimally instrumented, and the EDTA does open up and remove any smear layers, so this will flow into whatever Mother Nature gives us. Okay, and single cone techniques is an option. A lot of users are doing that. I don't. I am going to do kind of a modified continuous wave here. Basically, I'm just searing this off and compressing as much as I can, as far as I can. Add a little bit more sealer. You can reapply sealer if you feel inclined to. Just want to see how far that went. Will you hand me another cone? Okay.
You good?
Yep. And I'm just backfilling, just watching the sealer come up and around. Sometimes when it gets a little sticky, if you just want to dry that a little bit. put a little, wipe the tip with a little bit of alcohol, and it helps not lift so much. Are we doing a temp or a perm?
Perm.
All right. So in this, for instance, we're actually going to do a permanent restoration, and I'm going to lower this obturation just down to the CEJ. All right, microbrush. So this is just alcohol on a micro bendy brush, essentially. Just going to remove any film, any remnants that are in there from my obturating material. Dry this out. I'm also going to use a conditioning agent. It's a two-step bond that I'm using. Parabond, and it kind of replaces acid etch. So conditioning comes first. Just scrub it everywhere. Dry.
Bond.
And now this is a two-part bond that Lindsay has mixed behind me. I'm going to scrub this into place and just blow out any excess. Sometimes I'll even put a little paste point in there if it pools. 1 second.
You good with that or enamel?
Denton's fine. Actually, I'll use enamel. Okay, let's take a look at this here. I'm going to turn off my curing light. Okay, go ahead and cure that. You know, one of the debates are with a lesion of that size and even suppuration, do you just put calcium hydroxide directly in? And I think that's up to every user. For me, I find that this is really efficient, and I have had great success with bone regrowth. So one of the things we can do as time goes on is post-operative outcomes, I guess. All right. So take off the rubber dam here. And let's just clean a little bit around the tooth. A little bit of putty here. Okay, let's check the bite. Okay, tap, tap, tap. And bite and grind. This case, I used ribbon, AH+. I'm a fan of both that as well as BC. Thought processes between the two really depends on kind of just case by case. The flowability of VC tends to be a little bit higher, but it also dissolves if you've extruded a bunch. H+ not so much, or ribbon not so much. If you get a lot of extrusion, it's probably there to stay. If you want to flip that around and go full screen. So there's the final outcome of the case. I'm not quite sure how long that took us, Lindsay, but we're done. And you know, the things that I like about this is the predictability, especially in situations where there is drainage. Confidence is very high with it. Just to summarize, I think the most important part of the APM is positioning it right directly above the natural canal. And someone asked about, do I change my access? And I try to keep it as small as possible, but I am going higher up towards the incisal ledge. I'm not worried about undercuts like I was under traditional. I remember being taught to remove the cingulum or the lingual ledge. And I spent a lot of my time early on. I graduated in 05, but early on I was doing that, and not so much anymore because I can get around and into spaces that I couldn't get into before. So that's it. Welcome to my office. Thanks for watching. Lindsay, give him a wave. Appreciate you guys, and hopefully we'll have another case for you next Tuesday.